Essential question in prescribing opiates for chronic non-cancer pain is how to balance the risk of opiate and abuse and dependence. You can move this way. I'm sorry. With the benefits of pain relief. To achieve this balance, clinicians need an understanding of the risk factors for opiate abuse, an issue that is only partially understood. Mental health disorders were moderately strong predictors of opiate dependence. However, the prevalence of mental health disorders was much higher than the prevalence of non-opiate substance abuse disorders. Among users of opiates, for suggesting that mental health disorders account for more of the population attributable risk for opiate abuse than does non-opiate substance abuse. Male, younger adults, and individuals with greater days supply of prescription opiate dispensed in 2002 were more likely to develop opiate abuse. Clinicians need to carefully screen for substance abuse and mental health disorders in candidates for opiate therapy and facilitate appropriate treatment of these disorders. The onset of alcohol and substance abuse typically was associated with the onset of symptoms of PTSD, and the increase in use paralleled the increase of symptoms. Patients reported a tendency for alcohol, marijuana, heroin, and benzodiazepines to make PTSD symptoms better, while cocaine made symptoms worse. Opiates are commonly used to treat patients with chronic non-malignant pain. There is much controversy over the definition, incidence, and risk factors of prescription opiate abuse in chronic pain treatment. The present study, done at the Seattle VA Medical Center, was designed to create opiate abuse criteria, test inter-rater reliability of the criteria, apply the criteria to a group of chronic pain patients, and correlate the risk of opiate abuse with the results of alcohol and drug testing. Prescription opiate abuse criteria for use in patients with chronic non-malignant pain were designed. The criteria had good reliability and can be applied during normal clinic interactions. To range reported by others, past opiate or alcohol abuse or psychosocial testing on clinic admission failed to predict who would become an opiate abuser. The criteria can be used to identify patients who will subsequently require more intensive treatment or intervention, or can be used as an outcome measure to test the effectiveness of treating strategies. The general population are also found in the patient population of a national health system and provides further evidence of the population level association between trends in opiate prescribing and opiate overdose deaths. There is substantial regional variation in both opiate prescribing and opiate related rates, and these data can inform region-specific overdose prevention strategies and opiate policy. Approximately 20% of the U.S. population is significantly affected by pain lasting at least 6 months, most commonly back pain, joint pain, and headache. Individuals with non-cancer pain conditions now commonly receive opiates as treatment of their increased use in controversial, with some believing that increased use of opiates for NCPC is a sign of better pain treatment, while others warn that we do not have enough evidence of safety and effectiveness of long-term opiate therapy in NCPC to justify its use. Further, there are concerns about opiate-induced hyperglycemia and opiate-induced decreases in quality of life. It is likely that increased use of opiates Both improves pain control and increases risk of misuse and addiction, reflecting the key use, balancing, and the benefits and risk. The Food and Drug Administration recently indicated that manufacturers of certain opiate drug products will require to have a risk evaluation and mitigation strategy to ensure that the benefits of drug continue to outweigh the risks. The percentage of chronic opiate users who become opiate abusers in pain treatment is within the range reported by others. Past opiate or alcohol abuse or psychosocial testing on clinic admission fail to predict who would become an opiate abuser. It is my concern that we are over prescribing medicine to our veterans, and they are heavily becoming addicted to these opiates. We have had many overdose on opiates, and I think that this is not something that we should be doing to, I guess, medicate our veterans. We should try other things like counseling, just other methods of helping our veterans. Thank you.